Good morning, distinguished guests, esteemed colleagues, and dedicated champions for community health. My name is Munguti from the Financial Alliance for Health, and it's an honor to speak to you all at the inaugural Zambia National Community Health Symposium. I extend my apologies for not able to be joined in person, but I do look forward to participating in future symposiums and other similar convening. I also commend the Ministry of Health and all the partners for organizing this significant gathering that is focused on accelerating investments in community health programs to build resilient, responsive, equitable, and sustainable healthcare systems. So as we come together to discuss the future of community health financing, really, it's important to understand the environment and the context that defines health financing in Sub-Saharan Africa. Firstly, is that African countries generally perform better in budget preparation than in execution. They actually outperform a lot of middle-income countries in Asia and even Latin America. We do so well in the preparation of budgets, in the formation of budgets, but the actual implementation and the absorption of budgets and the allocation of funds to the budgeted priorities and activities doesn't really happen. It's a different story. So these challenges frequently stem from weak internal controls during the mid-term expenditure frameworks and the limited capacity of public financial management amongst personnel, more so programmatic teams. So this contrast in budget preparation versus budget execution affects not only public health, but the infrastructure that supports community health programs as well. Secondly, budget transparency and accountability is a major challenge as well across the region. Although 2/3 of budget documents do reach legislative bodies, like the bodies that actually do approve and play the oversight role over the budget process and the allocation and the expenditure of budgets, only a limited number are publicly accessible. So 2/3 of documents are accessible to the legislative bodies, and less than that percentage is actually even accessible to citizens, to communities, hence hindering citizen engagement and also oversight. So this lack of transparency weakens the ability of communities to monitor public spending and advocate for effective resource allocation. For instance, a recent example is the anti-finance bill protests in Kenya that was spearheaded by the Gen Zs. So if structured public participation forums might have been done properly and gathered public views and reservations leading to amendments that could have averted the loss of human life, the economic disruptions caused by the protests, these highlight the importance of citizen involvement in public resource planning and spending. The current debt situation further compounds these challenges. As of 2021, 15 African countries were at significant risk of debt distress and defaulting, with 7 already in financial crisis. Half of the continent has a debt to GDP ratio exceeding 50%. Such financial stress and fiscal space limits the ability of governments to allocate sufficient resources to essential sectors, including health, creating a ripple effect that compromises service delivery and, at the end, especially at community level. So with this financing environment and context, there's an estimated annual funding gap of almost 5.5 billion for community health systems in Sub-Saharan Africa. To bring it home, the actual Zambia 5-year strategy requires around $75 million to be fully implemented, and with a funding gap of around $41 million. So this gap underscores the urgency of adopting innovative, sustainable financing strategy to ensure that community health programs do really thrive. So given the context, And to navigate these challenges and to really optimize resources, I would like to share with you 3 key strategies to enhance community health financing and domestic investments. There's no guidebook on how to fully fund your community health programs. There are many ways, many strategies and interventions that we could deploy. But for today's convening, I would like to share three strategies that I do believe that will be quite significant in enabling and being an accelerator to increase community health financing, with a special focus on innovative and sustainability and domestic resources. So, given the context that I've just provided, the first one is around the engagement between the ministries of health and finance. Continuous engagement between these 2 ministries, health and finance, is essential to unlocking more funding, sustainable funding for the broader healthcare system and specific priorities such as community health. So these engagements must operate in 2 levels: internally within the Ministry of Health itself, and externally between the Ministry of Finance and other line ministries, even legislative bodies and even executive bodies. So the internal coordination within the Ministry of Health is about ensuring alignment between the policy and finance departments and the programmatic units or even departments to create a unified financial plan that supports comprehensive health strategies and interventions. So this internal synchronization allows for the development of coherent budgets that address both immediate and long-term health priorities. The policy and the finance departments are critical and very crucial because they are the budget decision makers. They can either enable strategic investments or contribute to misaligned priorities. This distinction could mean the difference between procuring essential drugs during a cholera outbreak versus purchasing ward beds when there is not even enough space to accommodate the beds within the facilities. It's the balance between allocating resources for training community health workers and allocating money for office renovations within the Ministry of Health. So it's a very distinct balance on how important the finance and the policy department are very crucial within the budget or even within the allocation of resources. So secondly is zooming out is the external engagement. And these are dialogues, coordinations, conversations between Ministry of Health and Ministry of Finance that should be continuous throughout the public financial management processes and the medium-term expenditure framework cycles to facilitate realistic budget allocation that really prioritizes health. So this ongoing communication that needs to be continuous, not only at the start or the beginning of the budget preparation, but also throughout to the approvals, to the execution, right, and even to the oversight. So this ongoing communication ensures that health needs are clearly articulated and aligned with the national fiscal policies, and fostering budget commitments that actually translate into actionable resources. So think of this way: the Ministry of Finance decides the overall size of the cake, the budget cake, right? While the engagement between MOH and MOF influences the size of the slice allocated to the health sector. And within MOH, the internal coordination between the programmatic teams, the policy teams, and the finance teams within the Ministry of Health determines how this slice is shared among competing and ever increasing health priorities and needs. So this dual layer engagement not only strengthens budget credibility, but also secures commitments and that are more likely to translate into executed resources. Regular joint reviews, meetings, and stakeholder coordinations and steering working group committees between Ministry of Health and Ministry of Finance can further identify bottlenecks reallocate resources to areas of urgent need and really enhance the effectiveness of health spending. So that's the first strategy. The second strategy is around providing autonomy of lower level facilities or primary healthcare facilities in revenue collection and spending. What do I mean? I mean by empowering these primary healthcare facilities or these lower facilities to collect and manage their revenues presents an opportunity to ring-fence funding for community health services. One compelling example comes from Kenya, where in law, through the Facility Improvement Financing Bill or FIF bill, has enabled facilities to autonomously collect revenues from user fees, insurance claims, and conditional grants and other resources, and they have the authority to retain these funds and to spend without surrendering the funds to the local or national governments. What used to happen in the past is that once these facilities have collected this money will be sent into one consolidated account at the local or at the national level, and then this account goes to either to the treasury. All this money from other sectors come, then they are reallocated back. Then and again, that's where we used to miss a lot of, and this money would go to other priorities. And so with the FIF bill, the counties or the facilities are able to retain these monies, that all these revenues they collect, and manage and actually do the actual expenditure without submitting or sending this money. And a good example of how this has very worked well for the case for community health is one of the devolved subnational governments called Nyeri County. So it's in the central region of Kenya, where there is autonomy, where this autonomy has allowed lower level facilities to retain all revenues collected, all allocated to the facility, and the facilities are mandated to allocate at least 10% of these revenues to community health services, right? And this directly supports the community health workers who are linked to these facilities, and they are providing complementary, right, resources in delivering essential services, issues around supply chain, and even equipment, and any other community level activity that the community health worker undertake. So zooming out, this financial independence enables facilities to respond swiftly to local health needs and really invest in critical areas such as community health without really delaying or experiencing delays or misallocation or misalignment from central budgetary processes. And I think applying such a model in Zambia could involve re-establishing similar legislation just to ensure PSC or the lower facilities retain and manage these collected funds that they collect or that are there allocated. Then ensure there's a specific mandate for community health investments within this legislative or this bill or this policy. And this could provide CHWs with the financial support needed for better services delivery and also ensure a steady flow of resources linked to facilities. Additionally, the reinvestment of generated revenue could fund training programs, essential medical supplies, even outreach activities, and significantly boosting health outcomes at community level. And finally, is that initiative more of a strategy, and this one is more of an innovation and a model that I would like to highlight, is known as CHUSLA, Community Health Units and Saving Associations, CHUSLA. So this initiative is designed, or model, is designed to address the challenges faced by an estimated 3 million community health workers in Africa, whom over 80% are unpaid or work as volunteers and are predominantly women. This context limits the ability of CHWs to deliver consistent and quality healthcare services to underserved communities. The high attrition rate among the CHWs, driven by lack of financial stability, costs the health system significantly. as each CHW replacement involves further recruitment and training costs, and we estimate its cost around $400 to $450 to recruit one new CHW. And I feel like this is an unsustainable expense for many countries with already strained health budgets. So the CHUSLA model integrates community-driven financing with strategic partnerships, enabling resources to flow directly to CHWs and supporting their livelihood while sustaining service delivery. So the CHUSLA model begins with the selection and formation of associations made up out of 40 CHWs, like for the case of Zambia to be 40 CBVs within maybe 1 or 2 or 3 neighborhoods, who choose to join based on mutual support and their shared connection with the same catchment area, for example, as I said, the neighborhoods. So once formed, these associations undergo registration as community-based organizations, formalizing the operations to meet country-specific legal and financial compliance requirements. Training and support is then provided to these CHWs, equipping them with financial resources, so as part of the associations, around basic accounting and management skills, alongside specialized entrepreneurship training to identify and manage viable income-generating activities. So once trained, members pool their savings, and a seed capital is injected into each association to catalyze the savings and the loan fund. And group accounts and mobile platforms are also established where it's possible just to ensure transparency and accessibility of this financing information or data and resources. So CHWs can invest and set up businesses within their communities and also individually take out loans at very low interest rates for personal projects such as farming, business expansion, home improvement, and thereby empowering them financially and empowering them socioeconomically. Loan repayments with interest contribute now to the growth of the association's fund, creating a sustainable cycle of lending and growth. And at the end of each 12-month cycle, savings and the interest earns are distributed proportionally amongst the CHWs or the members. And the initiation of a new cycle then incorporates new members and refines processes based on lessons learned. So we do feel like the economic and social benefit of this model are quite significant, of this CHUSLA. For example, and it has been adapted from the successful model Village Saving and Loan Associations that has been deployed globally and also very widely in the region, where it has shown that for every dollar invested in such a model or an association, participant savings can increase by up to $20. That's an X20 increment, right? Really boosting household incomes, and at some level, it has really improved food security in majority of these regions where participants were involved in such initiative. So the CHUSLA initiative further stands out by embedding financial resilience directly within the ecosystem. These ensure that CHWs are not only retained but also thrive actually as empowered, financially independent health workers and professionals. So beyond the financial empowerment, CHUSLA enhances CHW's cohesion and support networks. Regular meetings, for instance, during the association's internal meetings, create opportunities for CHWs to share experiences, to discuss challenges, and collectively problem solve. So this collaboration fosters a sense of ownership and accountability, making CHWs more engaged and motivated to deliver high quality services. So at the Financial Alliance for Health, we view CHUSLA as a key initiative to advance both the recognition, professionalization, and institutionalization of CHWs across the continent. And we hope, together with the Ministry of Health and other ecosystem, we could make this happen in Zambia and actually be scaled up in Zambia. So as I come to an end, investing in community health is not just a financial commitment. It's a moral, and strategic imperative, addressing funding gaps through certain MOH-MOF engagement, empowering PHC facilities with revenue autonomy and spending autonomy, empowering innovative models such as CHUSLA will move us closer to a future where community health systems are resilient, responsive, and sustainably financed. Let us seize this opportunity to make tangible progress, and I look forward to seeing Zambia lead by an example, be an exemplar, and inspire the region in adopting and transforming strategies that ensure community health is not just a vision, but a well-supported reality. Thank you, and I wish you a good day ahead and a good week ahead as well. Thank you so much.